me to kind of come and just give a little primer on how to kind of be helpful, get things situated for the surgeons when we have an open chest situation over here. So yeah, Amanda was kind enough to help me from an OR perspective. To understand why we need to reopen the chest is pretty obvious, I think, but just to go over a few different reasons that you may not have thought of. To get a better understanding of the equipment, and I think that's probably the most important part. I think everyone here probably knows why we need to open the chest. There's just a lot of equipment, a lot of words that people aren't always familiar with. So a lot of equipment that people aren't familiar with, and a lot of procedures that people aren't familiar with, and just to kind of familiarize you guys with that. To learn how to be an effective assistant, I know recently we had some situations where it just so happened that the OR team that was on were all people who live kind of far away. We can live, so you never know what you're going to get. You could be lucky and have a team that lives close in, everyone's here really quick, or it might be a situation that kind of happened like a couple months ago, and everyone has to kind of figure it out on their own because no one's here yet. So that's kind of the downside of not having a team in-house overnight.
There's also, remember there's a little bit of trickle down time from the time that you know, like that notification cascade. We've tightened it up as much as we can, but there's still usually 15 minutes between when the surgeon knows that something needs to happen and when we know something needs to happen. And we're also working on kind of fine-tuning the vocabulary so that we know how urgent the case is.
Yeah, can't always communicate to us what the situation is. Like you may come in and we think it's a no big deal, and you find it's a CPR in progress, or vice versa. You come flying in here because you think, you know, when you're driving 90 miles an hour on the road to try to get here, and you come in and they're like, well, we're thinking about taking the patient back to the OR.
Of
how quick people
time.
are here. Yeah. The other thing we're going to talk about briefly is just the risks of reopening the chest. I don't know if the surgeons are ever going to take it to where they want you guys actually to be trained to actually do the opening, you know, or if they're going to just take it to the point. I think right now we're going to start with taking it to the point of ideally getting prepped, ready to go, drapes on, getting everything ready for them so when they walk in you can hand them a knife and they can get going, because that's a big time saver in and of itself. But we're all going to talk briefly about the risks of reopening the chest. If you were to stick your hand in there, what are the dangers? Because you can cause a lot of damage if you don't know what you're doing. And that's just another thing to kind of think about. So why do we perform emergency resternotomy? Obviously, it's due to some kind of hemodynamic instability. If the patient were bad enough, we wouldn't go through the risk of doing it at the bedside. And cardiogenic shock, sometimes these are kind of your patients that have kind of been here for a while, maybe they've been here a week or two, maybe they're septic, they're just not doing well, you're not really sure what's going on, but you're going up and up on your drips, they're acidotic, you know, things that look good on the echo, and sometimes you want to open that patient. And that's usually a little bit more controlled, and that's actually a great situation to kind of practice on if you're ever around and you see someone doing that. Get your hands in there, even if it's the OR team that's here. If there's room, ask if you can kind of, you know, at least be in the room and watch what's happening, because that's a time when things are a little slower. We usually know that you're doing it, and it's a little bit easier to, kind of things are at a different pace. Bleeding is usually your acute situation. So right after surgery, bleeding, tamponade situation. A lot of times we can see that on the bedside echo, and we see it coming out of the chest tubes. Can also be in a situation where I've had it where the patient gets extubated and then something happens, they cough, whatever, chest tubes start to fill up and you have to start all over again. And that's not a great situation, and that's usually probably one of the most urgent ones when you see that something clearly has kind of blown open and you have to get in there as quick as you can to try to palliate, so you can get back to the OR and fix it definitively. Sustained arrhythmia, that's not as common, but we have had patients that have, for whatever reason, gone into VTAC, VFib. You may not know what's going on. It may be a situation where they may want to open here if you have a refractory arrhythmia that you can't get the patient out of. Obviously, it's not your first line of defense, but after drugs, after shocks, sometimes they want to open up at the bedside. At this point, we probably would just throw the patient on ECMO these days, but it is another reason why we might end up doing this. And then I have actually seen this loss of epicardial pacing with nothing underneath the pacemaker. Nothing underneath the pacemaker. I did have Dr. Spear one time, like, rip a chest open because we lost capture and the patient had no rhythm. And so he opened the chest, put new wires on, and we were good to go. So not as common, but something that you can also see. So we're going to kind of talk, this is just an overview. We're going to break this process all apart over the next hour or so. But obviously, CPR is going to be your first thing, to have somebody designated to do that. have another person call the surgeon as soon as possible, because as Amanda said, there's a lot of time between when the surgeon's assessing the situation, when he actually gets on the phone with Access. Access sends us a page. We all have to call back. Sometimes it's busy when you call back to, notify. So there's a process, and everyone has to get their butt out of bed if it's the middle of the night. So it takes a little bit of time to, get yourself in here if you're trying to go as fast as you can. And Sadie wanted me to really kind of focus on delegation of duties, and we're going to have one person that's going to medically manage, and I'm not going to talk anything about the medical part and all those things that have to happen with that, but obviously I guess it's going to be the most senior ICU person that's going to kind of run the code, do the medical management. Obviously you have to have somebody else who's going to, if the patient is D-lined already, gown and glove and get some access in the patient. Those are the two priorities, along with getting the surgeon notified. Crowd control is a big thing, and you can see this is not even as many people as would probably be in this room if we had a code, and there's not a lot of room to move around. And like Amanda and I were saying earlier, surfaces, the more surfaces you have, the better, because you're going to need surfaces for everything. You need surfaces, ideally, for someone to put a line in. You're going to need surfaces to be opening things onto. We have the Mayo tray, which we're going to go over in a few minutes, but the more counter space you can get and the less people in the room, and you don't have to be nasty about it, but don't be afraid to speak up and just say, anyone who is not doing something, please wait outside the room. And you may need them out there, so, a safe distance away where they can hear. You may have to send people to run to get things. That's a perfect job for all of those extra people who want to help but may not have actually something to do at the time.
I would even say crowd control even outside of the room. Everybody was so super helpful that night with Saren's patient. Everybody was like ready and willing to help, but I unfortunately was running back to the OR. Yeah, I was running back to the OR for multiple things for various reasons, and I couldn't actually even get back into the room. So just remembering that help is helpful, but too much help, it starts swinging the other
Focus
direction.
on that too, like the charge nurse is supposed to
Yes, and
say, make sure everybody has an assignment as far as nursing, recording, and doing CPR and managing the
Exactly.
code part.
And if the charge nurse isn't right there, make sure that's clarified. Bedside nurse is giving the drugs, who's doing what. And the nurses are actually, I feel like, pretty good about getting themselves assigned to a job really quick.
Yeah.
It's just all the extra people.
Yeah, and then we send them away and make sure that the nurses that are in the room helping are covering, are being their patients are covered by the other nurses.
Good point. And we're talking about this a little bit more, but just be prepared with the patient's details, surgical details, if it's not the surgeon's patient. We'll get into a little bit more why that's important kind of further down. So we're going to start by going over equipment. And the primary equipment, obviously we have the open chest cart and the Mayo. And I was going to initially have everybody kind of go through all of that, but it's going to be changing within the next couple of months. Amanda kind of looked at that and was like, this is like from 1982, and I was like, yeah, it is. So I would familiarize yourself at least with some of the important things. Know where the paddles are. It's the left upper. Everything is labeled. It may not make a whole lot of sense. It may not be like great design, but peek in there. Know that the combination is 2244. Because it's also locked. The charge nurses know that, but that's the number 2244. Write this on
And you
your.
have to do it at the top of each
And
one.
yes, and then you have to switch. You'll hear it. You'll be 2244. And actually, here we can you should. Let's just do this. Yeah, because it's not. You also have a short period of time to open this. So if you do 2244, you'll hear the lock unlock. You have to do this because if you don't do that, it'll lock itself back up again. Okay, and then you can open it. So that in and of itself is a little bit tricky.
If I can just show up, the one thing that I already changed that won't be changing again is this drawer. The suture looks
I love that you put
different now.
That's great.
It's labeled a little bit more clearly. The rubber bands are gone. The rubber bands were compromising the packaging. So my hope is that this is a little bit easier to see, to find. If you want to grab one or two, if a surgeon asks for a suture, grab one or two and bring them into the room. Please don't take all of them. What happened last time was a whole pack of rubber banded suture got pulled into the room, so one or two could get open, and then about a half an hour later he needed that suture again, but nobody could find them because they got lost in the room in the shuffle somewhere. So there aren't a ton of suture on here. There is more than enough to do what we need to do, and that's okay, but just don't grab and drop somewhere because that will end up not working out later. A few small other things have been moved so far, nothing that is life-changing to anybody.
Nurses are required to check the cart, go through the cart 3 times a year, as well as the techs. And the techs have a really good.
And Sadie, that might not be a bad idea to make as a requirement for us to actually make sure you look at it.
So once you're done, that's what we're going to do.
Yeah. Yes.
It has, so
Very similar, yes, right?
this one got updated on Monday, this one just got updated today, and
The same code?
yes,
Yes.
yes. And the one on step down will be updated either today or this coming
I
Monday.
have one chest card, correct?
Yeah,
Correct.
We're trying to keep everything as identical as possible. So I would just tell you, eyeball it, kind of just familiarize yourself with some of the things on there. A lot of times it is the nurses pulling from that for us, but especially with the fact that there's a lot of travelers, especially at night and everything, I just think we should be as familiar with it as possible. So the mayo tray is where all your good stuff is. But you've got everything that you need there basically to get going, with the exception of we've got the blade situation.
The
which
knife
is-
situation.
the knife situation is always a problem, getting the knife in the handle and the blade, and I've had it where I can't find anyone that matches, and I've used the blade with my fingers, and so it's like, we're gonna, Everything that you need to get started is right there. Your betadine prep kit is there, your 2 suction tubings, your yank hour, and your lap drape are right on top of the mayo tray. And that's really all you need to get going. The towels that we're gonna talk about putting down, that's a luxury, that's great, but worst comes to worst, you've got your prep kit, you've got something, the lap drape, that's just one with a big hole in the middle. You plop that down and you're gonna be good to go. So, worst case scenario, open that prep kit, put some stuff here, have someone try to throw some towels on if it's that emergent.
Think ahead.
Yeah, think ahead and try
Get
to.
everything out of the way, right?
We're gonna talk about that too, that's why I put everything in the way. The yank hour, the suction tubing, ideally you want 2, we're gonna talk to you guys about how to pass those off. That's probably one of the most important things, because a lot of times we're opening for bleeding, and if you can't see, we can't do anything. So, and if it's true bleeding, you open the chest and it is just spilling out all over the place. It makes a big mess, no one can see, and the surgeons get angry really fast. The other thing, so that's a big deal. Make sure that somebody who actually knows how to hook the suction up is hooking the suction up for you. 2 half sheets or 3/4 sheets, lap drape, sterile towels. That's the ideal. The lap drape that we have in there is pretty big, so if you didn't have the half sheets to kind of go top and bottom like I would usually do, or if you didn't have the time, you could ditch that. And like I said, worst case scenario, you've got your lap drape and you could just go with that if you were in a good hurry. And then your gown, glove, hat, and mask, obviously. We were gonna talk a little bit about the glove situation. Those are all in the cart, and you guys know they're in the sterile supply room, the hats and mask and all that stuff too. I'll wear 7, 7.5, or 8. So if you could have those in the room, and unless anyone really cares, we're probably just gonna stock those yellow gloves, yellow wrapper gloves. They're a little bit better. They're easier to put on your hands, because you know those ones we have, the orange label, are like impossible to get on your hands, especially if you're sweaty and nervous and hot. And
We're gonna phase out the orange and phase in the
You guys got
yellow,
those,
so
yeah.
you can actually like put them on and then feel things. It'll be.
The blade, can we?
we're gonna talk
So
about all
this,
this.
the 19 last Saturday, they have the ready used blade taped on top of it.
Yeah, so it is.
Can we make that
It
a
is.
regular?
It's on there.
It is.
To
Yeah.
put the blade when you're like
No,
all
there's
in
this. See,
emergency.
this is here. This is taped.
Yep, that's what they
This
have.
blade right here.
So we're gonna do that.
That's how
And
it should.
there's an extra one of those on the cart, and then there's also an extra metal knife handle that's on the cart. And the one that I left there is the one that will also actually work with the knife blades that you have. So if you use the knife handle on the cart and the knife blades that are on the cart, all of those will work together.
That's a 10 blade.
Yeah.
And you should.
This is a 10.
That's the thing.
Yeah.
And I think that the only other thing is.
So this instrument tray is gonna change completely. That change is gonna be later. What this mayo that you're gonna see today in our simulation is the one that you have. This is what, if you open something tonight, this is what you would be opening.
Okay, so secondary equipment. This is stuff you're not gonna need all the time. Sternal saw blade battery. Amanda is gonna talk about that, kind of quickly go over how to put it together. All the events that have happened recently, the OR is keeping a cart with the saw, the blade, the battery, because you know it's 3 different pieces over in the core. And so I just wanted to show, at least most of you, everyone has scrubs on. We're gonna walk back there, but we will do that at the end, because there's a lot of us. And yeah, or and people can buddy suit if they want to come back, just to see where it is, because it may be you that has to run back there and get it.
And this is what the cart looks like. You're looking for a cart that looks like that with red emergency papers on top of it. Just so you know, it's about yay high, so you know what you're looking with, and everything that you want is in there. Do not take a cart that's bigger than this. You will get more than you want.
That's in the core.
That's in the core.
So we won't bring the entire thing over here.
You want to bring this entire thing over.
It said it's heavy.
I think
So roll it.
everybody's really excited about the saw situation right now because of what just happened with Dr. Saren's patient. But in all reality, his minis are the only ones that we're going to need that for.
Yeah, we'll just do Bovie now. Let's back up. So when you're getting the generator, and we'll show you where that is, you're gonna have to pass off the Bovie pencil, which is on the cart. Grab that. In order to use the Bovie, the easiest way to do it is, clamp this, if you have a clamp to your drape that we're eventually gonna have. You're gonna pass off the plug part, and that'll make more sense when we show you the generator here. We can pass this around. And everybody who's gonna be Bovied on needs a grounding pad to ground them. Otherwise, the Bovie won't work. The important thing about the grounding pad is that you have to make sure the patient doesn't have any metal underneath it. So if the patient, we usually put them here in the operating room, so we have to be really careful about hip replacements and things like that. Here, you're gonna be in a situation where you're gonna probably reach under the drape, slap it onto their thigh. You wanna have a meaty part. So usually the biggest parts of people are either their flank, that's gonna be too hard in this situation, their butt cheek, which is gonna be too hard, or their thigh, which is probably what you guys are gonna go for. And important question to ask the nurse before you're putting this on, make sure there's no metal under there, because that'll cause a burn. So, I don't know if you guys wanna see. Only if it's so bad that you don't think it'll stick.
Gel, it's like jelly
Here, you can
stuff
pass
like
this around
this,
too,
so it'll stick through.
It'll
quite a bit
stick
of
pretty
hair.
good. I mean, if you've got like the woolly mammoth kind of guy, that might be a situation, but my advice would be,
If so, they probably
try.
shaved them in the oval.
They probably did. It's probably shaved anyway. So,
This is one of those things that it's nice if you have time to put this, if there's time to put it on before you have put the drape on, so that it's there in case you need it. The Bovie pencil you don't need to worry
Yeah,
about
exactly.
until later. If this is already on, great. If not, we are very accustomed to climbing under drapes and putting things on patients, so that can also be done. My only thing is if you do end up putting it on the patient, to make sure that it's not so high that it's covering the groin, because there's a fairly good chance
Yeah,
that we
going
will
in
end up
ECMO or
doing,
something,
yeah,
yeah.
doing something in the groin eventually, so down. And then also you'll see, where did it go? You'll see the cord is like twisted and twist tied together. If you put it on the patient, please untwist tie it and like throw the
just
cord.
drop the cord on the ground. so
Yeah,
someone can
down
reach it, yeah.
somewhere so somebody can actually get it.
Would it be good to have those put on top of the cart as well?
That's not a bad idea.
Yeah, we
Because some
could.
people would actually think of it. It'd be
Yeah.
there, someone
Yeah.
might slap it right on.
Exactly.
Yeah, we
That's
can
not
do
a bad
that.
idea.
This is what they look like. The Bovie pads right now are under the cautery pencil in the second drawer. I'll put one here, I'll leave the one there. And then they're also on the like cautery generator cart. So there should be no shortage of Bovie pads.
I have a quick question, Liza.
Yeah.
So I've not been through an open chest yet.
Yeah, yeah.
So if we decide we're opening the chest, obviously the cart gets brought, but are we
Yeah.
sending people to immediately get the saw cart and the Bovie stuff
So you're
that
gonna
it's
know
all
if you need
there?
a saw, because think of it, the only
'Cause,
patients
yeah,
that are really gonna need
no
it would be
sternotomy.
like a sarin patient. If they don't have a sternotomy,
Sure.
they don't have to worry about it. I would not worry about sending someone to get the Bovie immediately, because
Okay.
that's gonna be a secondary
Got
step
it.
once they get everything under control. I just think it's good, I think if we know where it is, that'll be
Okay.
enough.
And that's like kind of in our cascade of things, that's usually something we grab and bring over anyway. So if you guys have it already, great, but I mean, very rarely is it something that's boviable that's
Right.
killing someone.
Yeah,
Like, that's-
exactly.
There's
Exactly.
like a bleeder on the inside of the chest is not gonna be what's causing the patient to
I mean,
bleed out.
yeah, so. Okay, so secondary equipment, internal paddles, and I think you brought paddles, right? So we just wanted to show you guys what they look like if you haven't seen them before. And the other thing is, Katie wanted to make sure that we kind of had an idea of how they get plugged in, so Amanda's gonna show you how to plug them in. Obviously, you're gonna pass the plug part off, it's pretty obvious which end. And these do need to be put together. Hopefully you won't need to ever do this, but just in case.
The nurses are all taught how to do that.
Good,
This
good.
is not what yours look like. Yours are blue wrapped and in that far drawer.
Yeah, they're in
If
that-
somebody wants to grab them, it says
It's in the
internal
top
paddles.
left, Shannon, and it says paddles. Left side? Yep, top left.
There are also, if you are opening a saw, they are in the box with the saw as well, which is how I got mine.
Yeah,
But
so this
in most
is-
cases, you're not gonna need a saw. In most cases, if you need internal paddles,
This is
what
how
you're
ours
looking for.
come. They're in a plastic case in there. We're gonna talk about opening things sterilely in a few minutes. This is probably not something I would go for immediately. First of all, is your patient in shockable rhythm, okay? If your patient's just hypotensive or, in PEA, it's probably not gonna be your first thought. Know where they are, know how to hook it up. So I'm just gonna have Amanda real quick show you how to plug those in, show you how to plug this in because that's a deal. And also, I just wanted to talk about real quick to make sure that we know how to change the lead when you. So when you press lead, you have paddles as your first option. If you keep pressing lead, it will change. You are probably not going to be running this. The energy that you would defibrillate with this is way less than you would, and it's usually 10. You start with 10 joules.
It only goes to 50.
I was going to say, we normally use 10 to 30.
And when you plug this in, it defaults to 10.
Yeah.
So it knows that you're plugging in internal paddles and it defaults to 10.
Usually the surgeon will tell you what to.
They'll tell you what to do.
100% of the
Yeah,
time.
and
they
it's
will tell
been
you.
But just know, I just wanted everyone to know that when you, for like a 200 or something like that, it's going to be way less energy. And the other thing to know is when you shock with those, you don't have to not touch the bed. So don't freak out about people not standing. Yeah, so don't, when we shock with the internal paddles, you don't have to back away. So just, if you see that.
And this is not a shock at the machine situation. There's a, they shock here.
Yeah.
So this is sensory control.
You will
charge
the
here,
regular
you
way.
shock here.
Lisa, I'm gonna have you do this because I know that you're smoother at it than me. Because I know they plug in here, but I'm not good at it. So
The trick
So
is, so when you put it in, it always to 3 o'clock, and just push straight in and you'll hear a click. And then to
if
get
they
it
have-
out, it's hard for the guys with big fingers.
yeah.
You have to grab the little thing and turn it counterclockwise and go straight out.
That was a little tricky. And then you would plug your same
Plug
way.
this, so just plug that right in. And then even when I do charge, it's charging just kind of. If you want to dump the charge because you change your mind, you can just change the energy select.
And it'll get rid of it.
And it'll stop it. So, I mean, it is kind of, this is a
weird
problem.
mechanism.
We make
yeah.
everybody go.
Yeah, does anyone feel like they want to try that right now? If you do, now is your
I mean,
opportunity.
both of these are the
but-
same. You just take one off, plug the other one in.
This, loading these is gonna be a push and a turn situation.
On a tidy left.
You'll feel it, yeah, we can pass these around, and then pull to check. If you do not pull to check and they are not in, even though they look like it, they will put them in your cart, and
Obviously,
then
you're
that will happen.
only sterile people.
It's
And all of
embarrassing.
us have done it.
Don't do that with your bare
Yeah.
hands.
Oh, yeah. No, this is after you're sterile, gowns,
Yeah.
gloves, whatever. But it is helpful to feel what it feels like.
Yeah, pass those around and then.
And then they should be holding it, like this, well, yeah, like this, so the paddles are facing each other, and then they can just do it with their thumb.
Probably in the next 6 months, we'll have paddles that are
To get it,
put together and you will not have to do that anymore.
Oh, really?
So, yes, there are a lot of good changes coming, but for right now, push and turn.
The only other thing I have on this list is the overhead light. It's a luxury item. It's not the first thing you're gonna grab. I'm just saying they may say, where's the light? Because sometimes they want it. They're used to using a headlight, so they can't see anything. They probably don't have their loops on, so they're gonna be blind. And sometimes they call for the
It's
headlight.
nice to have it.
Yeah, which is over in the back corner. Yes, that's where it always has historically been. It's a big, neck light. How to gun and glove yourself, and ideally the surgeon. Talked about hand sanitizer first if possible. Okay, and the easiest way is to, open, always open away. And this gives you a square of sterility. And you might be able to pop a couple other things on there that you think you're gonna need. Put your gloves on there too. And then when you pick up your gown, obviously, you can touch any of this. The only trick I was gonna teach everybody, because I don't know if everybody knows this, and maybe they do. But this was a trick that Jen Kurz taught me a million years ago. Because there's always not someone to hook you up. And this is not an OR technique, but if you grab your Velcro like this, and Velcro behind your head, you can get yourself into your gown and at least get going without the gown around your elbows if there's nobody there to, hook you up. And obviously, until you have gloves on or keeping your hands, keep your hands beside, because that gives you at least the ability to do something with your hands. If I'm sterile already and someone else is scrubbing in to help me, to make it, it is a lot faster for someone to put your gloves on for you than for you to fumble with it yourself. So I've also been in that situation where I might be sterile already, and one of my colleagues has scrubbed in to help me do something. And if I have them right there and I have a second, for me to just hold the glove up to them and then put their hands in really quick, it is faster. So when you're gloving somebody else, hand them the right glove first.
Every single one of them gloves right hand first.
Yeah.
Just curious.
So
Yeah,
if
they
she's
use their help.
so
they
if
use their
she's
right
gloving
hand.
me, so if you're gloving somebody, what I say is, do you see there's writing on the cuff of this glove? Can everyone see that there's writing?
Uh-huh.
If you hold that up towards the person that you're gloving, they'll be able to put their hands in.
A quick this, again, time sensitive, but like a quick this will help everyone involved.
Flip
So
it.
you're already
That
gloved.
person has-
She's gowned and gloved.
I'm
Okay,
gowned
that's
and
what it
gloved.
is.
I'm helping my surgeon get gloved. Quick this, thumbs in,
Writing
Point
towards me,
surgeon.
and that's going to allow me to put my hand in easily, okay? And this is a
And then they use their right hand.
And
to
then,
help
yeah,
with
so
the
the
left.
second
That's
one-
so
why
I'm
the right
pulling this
first.
out again.
hand once I have this on, and I can put my second one in. So anyway, that's just a really easy way, writing towards the person that you're gloving, give them the right glove first.
These are 7.5. These will fit on every single surgeon's hands. If like, please do not spend time worrying about what
Yeah.
kind of gloves to put on yourself or someone else. Get 7s or 7.5.
Yeah, 7 or 7.5 are gonna fit the majority of people, and even if, how to prep with betadine. I'm gonna have Amanda go over that real quick. And before she does that, I'm going to talk about repositioning everything on the chest, because that's a thing. It's betadine for everybody unless it's an allergy. I guess if there is a true topical iodine allergy, you would use chlorhexidine. It's not a great thing because we don't have the drying time. That's the difference. That's why we use betadine. Betadine does not need a drying time, a dwell time. In the operating room, we prep with the chlorhexidine, but we wait 3 minutes. If it's an emergency in there, we just go ahead and prep with betadine because you don't have to wait that 3 minutes. Better than nothing would be chlorhexidine if you have a true topical iodine allergy, and just to have something on there, even if you can't wait the time. You're gonna obviously have hat and mask on already. You need sterile gloves. You don't need to have a gown on to prep. So sterile gloves are enough. Talk about starting from the center, working out, and we're also gonna talk about real quick the CPR situation. So obviously when all this starts, someone's gonna be doing CPR. And probably one of the first things that should happen, someone's calling a surgeon, someone's running the medical thing, someone is getting sterile, someone else, and this can be a tech, can be a nurse, can be an anyone, okay? Needs to get sterile gown and gloves, hat, mask, all that stuff on, and be standing there ready to take over sterile CPR once we do get the patient prep, because that's what we do. Once there's betadine on the chest, and you don't have to wait for the drapes, ideally, get the betadine down, that person can take over and start doing CPR sterilely. Then we can go ahead and drape around that person, okay? Because they're going to be up here, and it's going to take a quick, when the lap drape goes over, a quick, but the other thing to think about is this is kind of how, similar to how all of our leads are usually set up in an ICU setting. In the operating room, for these combo pads, we take this one, and we put it underneath here, underneath the right shoulder, okay? It's not perfect because this one can't be up super high, but you do get a diagonal, hopefully through the heart. This one can stay on the side, but that's something that you have to think about. A lot of times we've been shocking these people ahead of time, so if they have combo pads, flip that one around and put it in the back in case you need it for some reason to externally defibrillate. The other thing is, these things, peel these wires back, this will peel and separate. Get it down to the belly button at least if you can. Sometimes you have to actually move these wider, which is fine. UPKG may change a little bit, but move these down, clear this space here. And sometimes what I do, I grab silk tape and I'll just silk tape this down here, okay, so that everything isn't in your way and not popping back up here when you're trying to prep. If there's pacing wires and your pacing cables, pull the slack out on them, okay, and keep them below here. Sometimes I tape those down here. Have them plugged them in if they're not plugged in, so that people can actually, if we need to pace for some reason, they can access the box.
We usually have the box down here, so especially initially when they come out. So if they're draping, we don't have to do the drape crawl and find it under here.
Exactly. And
It's
if for
there,
some
somebody
reason-
at the end of the bed can manage it.
And if for some reason you see the wires still bundled up here and maybe they've been grounded already, they're not, plugged in, try to think about pulling those out. Ask someone else to come plug it into the box, get your cables. But don't keep that all up in the field, because then it's not gonna be accessible to everybody, okay?
Worst case scenario, there are sterile cables out there. Worst
Yeah.
case scenario, you get prepped and draped and realize that those are still here. You can open sterile cables and we can pass off the end
Pass
of the
them off that
cables
way.
like we do in the OR.
Yeah.
It's not our
Not the
first
end of the
choice,
world, yeah.
but there is a workaround.
So basically you just wanna clear yourself a space like this, okay? And then you can start your prepping process. And Amanda, just kinda go over.
The best case scenario also is just to have stuff off of the sides. If you need to keep stuff in the middle, chest tubes, wires,
Yeah.
whatever.
Yeah.
But if you also have a chance to throw some stuff on the groins, that would be super helpful. Your drape is obviously only going to show this, but we very routinely cut holes in the drape down here to get to the groins. They will do that even if the patient is not prepped. But again, in the interest of time, if you have a second to also just do this motion, that's great. What you guys have on your mayo on the very top is this open heart prep tray. It is very similar to the one I will be opening, except the betadine is actually in here. I'm just going to show you, I'm gonna actually open a cheaper one. This is a cheap thing I can open that shows you how almost everything is folded. So this is exactly how the gown was folded, right? This is exactly how the drape is gonna be folded. There's like only 2 or 3 different ways to open a sterile package, and this is one of them, right? So there's plenty of other trays that you guys open that are like this too, right? Okay, so we can actually use this one since it's what you'll have. These are both gel in your guys' now. They're solution, and the only thing that we have over in the OR are solution. So this is gel. It's disgusting. It's hard to spread around. It's hard to like squeeze out. Just know that when you're opening it, it's going to be actual like liquid
It's gonna be solution, so yeah, if you've been here a long time, you would expect gel, and it goes all over the
Yeah.
place, yeah.
So you're gonna dump solution. I do not use these for anything. If it was just me, and it's usually not just us, right? But open this, step over, put on my sterile gloves. You put on your sterile gloves first.
To make sure that's open sterilely before you put your glove. You know what I mean? It's just sometimes you don't think ahead when you're like in a.
And then you can mess with everything. Touch, prep. So we'll start in the middle. It's very simple. Also, nobody really cares in this situation. middle to outside. Change this if you need to. We really like to like get around chest tubes if there is time for it. Chest tubes are disgusting. But so all around that you can. Ideally up to the chin, that's probably not going to happen in here. Ideally down to the umbilicus, probably not going to happen in here. And ideally nipple to nipple is like our ideal. How close you can get to that is a different matter. And then both groins, most likely with a different one of these, if you can. Again, middle to outside, middle to outside.
And ideally, don't do your groin and then do this.
Oh,
at the
please
same
don't.
time.
That's not even ideally. Just don't do that.
Just saying. Stranger things have happened.
Just don't.
Wipe front to back. Okay. In the interest of time, swipe it and be on your way.
And then throw this away. Take this fluid-filled betadine thing
Get
and
rid of
move
it.
it clear off your surface.
It'll
Yeah.
spill.
And yeah, please don't leave that on
Okay.
on the bed.
Oh, the only thing I wanted to mention, like she said, so you've got your non-sterile person doing CPR, okay? We've prepped. That's when you bring that other person in, okay? Gown, gloves, everything.
You're gonna have to have a few people sterilely prepped.
Because they're gonna have to change out. Good thought, Courtney. They're gonna be doing their CPR. And we're gonna talk about, I think I'm talking about drinking.
And the most important thing is to keep CPR going,
Yes,
because I think all this is great, but CPR cannot be.
cannot be
Delayed.
stopped. So the only thing, so the way I kind of wrote it here would be an ideal situation. Ideally, if you have sterile towels, towel off your area, kind of like you would if you were, doing a procedure with, I don't know, I'm old school, I like towels and plain drapes, but towel off your area if you have the time. And then I like to throw one up, a half sheet up and a half sheet down underneath, or, at least from the groin down.
Do you want to just do?
We can just do it.
Okay, so you be not sterile.
I'm being not sterile.
Okay. I have gloves on both of my hands. You're doing CPR.
I'm doing not sterile.
There's another, she's gonna be sterile magically in a second.
Yeah.
She's gonna pause. I'm gonna
She's
prep
gonna swipe.
this sterile
person's
person.
gonna come in.
Yep.
Sterile person continues the CPR. Blah, blah, blah.
Another sterile person. So this is having multiple sterile people. Another sterile person, or another sterile person can come do.
And I'm CPRing, yeah. Ideally,
This.
throw your towels, and cover the face, because there's always spit and everything, and to try to keep that stuff out of the chest, I think is
Well, and our surgeons are used to having kind of a guard over the face too, so not like throwing stuff up there isn't really on their mind.
So you're gonna have ideally 4 towels around.
I was like, I had 4.
And then we have a lap drape, right?
Yeah. Individually, it's all gonna be in one pack.
So you
that we're
everything
gonna
in, so
open.
that's what she's trying to get
And
done.
so, yeah, the towels, all of the drapes, a couple gowns, laps,
That's amazing.
gray tech, all of those things will be in one place, and nobody will have to run to the cart
to
100
get open
times.
all these other
Yeah, as the
things.
surgeon
Yeah.
opens stuff.
That's-
It is a painfully slow process, but I'm working on it.
That's, yeah, ideal. And like I said, if you don't have your top and bottom drape, that's fine. If you're in a more controlled situation, like I said, I sometimes just put it here underneath, especially.
It's nice to drape the whole bed, because if they're gonna put up
Exactly.
that ACMO,
Yeah.
the wires and the cannulas. kinda
Exactly,
go
and
all
this
over
is
the
pretty
bed.
big, so yeah, also if you have naked space on the bed that you see bed, that's another reason why you have, you know, covering that. And if you cover the top and bottom with those other drapes, then if you miss it with this, then you're okay. But like I said,
Yeah.
that's, you know, in a perfect world.
So this is another area time you need a surface. Somebody that's not sterile can obviously open this, but then somebody that is sterile needs to take this. It's very self-explanatory.
Picture
Has
of a man.
Picture of a man, so you know which way. It does matter.
This is short up here.
It's not the end of the world if it gets open upside down, but it does matter. You can do stickers off first, and then it sets.
And if you
it
don't have the
goes
stickers off, that's not the end of the world either. It tells you
2 foot.
so you hold 2 foot. And this says,
Because I think these cover.
this
now.
is pretty big, actually, you're
Yeah.
right. We don't even, yeah. These are way better than they used to be. So there you go, boom. And you've got, ideally, you have sticker, and to be honest, since it's wet with betadine, it doesn't stick very well usually anyway, so if you don't have your stickers off, that's not the end of the world. But if you need extra, you know, drapes for anything,
This isn't what I thought it was. Well, this is, so just so you know, the 3/4 drapes open differently. They'll
To
open
the side.
out
like that way.
and
yeah.
then up and
You
down.
need to throw.
Yeah.
Okay, so that's, okay. And now we're gonna talk a little bit about passing things off, now that we have our sterile drape up. We're just gonna have, we're gonna pass off suction, I think that's probably the most important thing. And then we're also gonna get into eventually opening the tray and kind of showing you guys with the clamps and everything, how to secure things to the drape so they don't fall off. And like I said, when someone who's not sterile is trying to open something sterile for somebody, you're both moving, you hit hands, and then it's like I said, once you're draped, the easiest way is to just pop it out of the drape. If anyone doesn't know this, open the wrapper like this, hold it away from you, pop it out of the drape. And you can put all kinds of stuff. This area in between the patient's legs is a great area to just kind of pop things open that people are asking for. People are gonna be asking for a whole bunch of things.
Especially if you're opening stuff for us, we are gonna ask for something and then we're gonna go.
Turn around and do something else. So
Yeah,
don't
we're gonna
expect somebody to
immediately go
actually.
do something else and expect it to be in front of us in the next minute or two. So don't worry about like standing there with it half open. Please just throw it on the drapes unless it's a knife blade. Big accept, but everything
Can I open
else
this,
you
or should
can
I go
throw there
around?
and we'll find it.
Yeah, you can have it. Okay, yeah. So suction, like we talked about, we have it on the Mayo tray. One of the most important things, and we'll show you kind of how to anchor things.
It's our large suction. This directly connects to the wall. Don't connect it there, so you might have to take off one of these, but it goes straight in.
The techs
Kind
are
of-
very
kind of
good in
hard.
getting all these
So
things
that's
good.
connected, and then we had the suction tubing for them. So all these are turned off this way, and since they're for them, so what is actually gonna happen is I'm gonna have the suctions, I'm gonna open one sterilely.
Give it to me.
They're gonna give it, and then we're gonna take a second one and hook it up, and then she's gonna pass it back to me.
Because usually it's not long enough. Usually we plug two of these in together, but sometimes, I mean, in a situation like this,
So
this
this
is
will be
plenty
hooked
long.
to the other one that I'll have hooked
So you
to
can
this.
have length.
So it'll be twice as
Yeah.
length.
Which one is open? Sorry, this is.
Well, right now they're all off, so if I'm gonna use this one, I will put it on, I like to take these off because I don't think they're as secure. But you go like that, make sure these are all on, then turn this on, and you can hear that it's, and you go, do you have suction?
Oh,
And you
no,
al-
I-
we
I
also-
don't.
It's not connected, the red top.
Oh, you're,
Yeah.
The red top.
Yeah, I would recommend checking it at your site first and
Yeah.
then connecting it there.
Otherwise we'll be screaming, no, suction,
And
no
we
suction,
also
no
hand off
suction.
the, we also
That's
hand
our
off
favorite
the
thing to
suction
say.
thing to use sterilely. And then if it gets full, then they're supposed to say, we need to change the
The
suction.
suction's not working.
It's because it's full. Is this a good time?
Yeah.
And turn it on and turn this one off so you get the most suction. You can see that you have suction there. and then you just go round and round.
You might be on them in the night when you have a lot of new people,
Yeah.
and maybe they don't know how to work this. So,
Yep.
you know, it's something that we need to be able to supervise, and just to, you know, something stupid like this could create chaos.
Yeah.
You know what I mean? If this isn't working, you can't do anything in here. You can't see anything.
We go through, everybody has to practice passing off and practice switching and hooking it all up.
Yeah.
All the nurses and the techs have to go through that once a year, so.
Very good. Thank you, Lisa. This was helpful.
Another challenge that comes up is with the tubing. There aren't those like inner.
White connectors
Yes.
all the time.
Oh,
So
and when
that's.
Yeah, when you open the tubing package, it's not hooked, so it'll fall right on the floor. So just know that it's in the bottom of the package, you need to get it.
This one, I was gonna say, yeah.
Yes, that.
It always does, yeah, and the only thing, I mean, you can get around that if this is a decent length, so you could plug that directly, but sometimes
Yeah.
for some reason they seem really short.
They used to be short.
Right?
They're
And you're like,
Yeah,
you
they
can't
used to be
use
really
it, yeah.
short. They're a little bit longer now, so doubling it up is probably less of a priority, but still, I mean, extra length is
Never a problem.
Never a problem.
Yeah.
Also, if there's a lot of equipment in the room, I don't know if you noticed, but the tubing on that connects to the wall,
Can
we
be
can
long enough to
actually
move it
hook
out
it
of the
up and
way.
then have the suction outside
Yeah.
the room.
That's a good point. Does anyone have any questions about opening things, draping, any of that thing? Okay. We're gonna talk about the mail, which is your most important piece of equipment. I'm gonna kind of have Amanda go through, you know, it has a dust cover on it. We've kind of taken all the stuff off of it already, but that's how it comes. The dust cover. So, it comes like we had it there with your 2 suctions, your 2 yank hours, your disposable blade is taped onto it,
Yes.
and your prep kit. Okay, so those are all the things that you need to get going. And I'm just gonna have Amanda kind of go through just briefly. You take all those things off, get them somewhere else, and someone opens this. And once that's opened, and you're, you know, you can open those these onto it. Okay, to have it ready. You can open your suction, serial suctions onto there to be ready. Get that open, get your gown and gloves on, and then you can be ready to start, you know, draping and everything. You could have someone open the drape to you and put it there. So once that tray is open, it becomes a nice work surface too to open some of your other smaller things while you're, you know, someone else is prepping and getting this ready for you. What they're gonna need first is a knife blade, obviously, to cut through that. They may or may not need scissors. If you cut hard enough, you just cut through all the scissors or the sutures. Sometimes you need scissors to kind of cut through that. Then they're gonna ask for the wire cutter, and we'll talk about that. And a wire driver, okay, which is like a needle holder but a lot heavier to pull the wires out, okay? Those are the things they need to get in the chest, and once they get in the chest, then it's, you know, from there it's going to depend on what the actual problem is. So Amanda's going to briefly just kind of touch on basics, and don't belabor it because we're never going to remember it. I was thinking of that today actually. Dr. Ryan is the only person I feel like who ever puts staples in. There is a staple remover on that cart, but the other thing, when you are trying to get back in, you can use a hemostat, stick a hemostat in, spread it, and pop each of those open. It takes a long time. So
what about just making an incision next to where the staples are?
I've never seen anyone do that. If it was a true emergency,
I
you
mean,
definitely
honestly,
could do that. but
99% of the time there's no staples.
Yeah.
Dr.
And
Ryan
if you
is the only
do,
one who
then-
sometimes does it.
Yeah.
And to be honest, if you do get into this situation, that's something you could start doing ahead of time. If you guys get going and you see that, somebody get a staple remover and start taking those out. If the incision starts to open up, that's fine. We're doing that anyway. But I would say
After it's sterile.
prior
after
to,
it's
doesn't
wrapped.
even matter. I would say just get going on them. Try not to have them all falling in there if you can. Try to get rid of them.
Yeah.
Is going to put together sort of like a picture guide for us to keep in the office of some of like the important instruments that are on this tray, only because they're going to ask for things by name. Like, we're giving you all this information today. I know you guys aren't going to remember all this, and it's also, you are expected to know how to do something very technical that you might only do once a year. And it's a tricky situation. And, you know, for me, I was laying down at night, before I would like actually try to like go to sleep or anything, I would lay there and run through all like, what's going to happen if 201 codes? Like, what's my plan? And try to run through a lot of these things in my head so that I had a contingency plan. So when if something happens, you know, then I'm not reacting. I've already thought it through. And I used to practice things in my head too. Like if I hadn't done a line in a while, I would practice, you know, I'd think about it in my head, or I do that with, for example, like groin cut downs. We hardly ever do that anymore. We used to do it all the time. We usually do it percutaneous now, but a month ago, I had to cut down on 2 groins and put purse string stitches in the artery and vein. Okay, I haven't done it in a year, but it's something that I know I don't do often. So I take the time to practice it in my head, and it sounds silly, but it makes a big difference. If you kind of go through, so if you take, keep these notes and run through, when you have downtime at some point at work, just take 10 minutes and refresh yourself. Think about this stuff, because even if we do it a couple times a year, you may not actually get to do the skills for a year or 2 years, who even knows. But as long as you've kind of thought through the process, so that's half of it. And same thing with those cars. I mean, it sounds silly, but to know the names of just some of those basic instruments, so then you feel more comfortable, keep it fresh in your mind. And I think we owe it to the patients to do that, because this is a big deal that we're expected to, I think that we're expected to know that we don't do very often. That's really hard to do. So,
And be in the rooms when somebody goes bad. Don't be shy and don't be outside. Just be in the room. The more you're interested to learn, the more they're willing to teach you, like Dr. Saren did. He was teaching them to cardiac massage once he got need to be right in there.
Even if you're not gonna be a part of what's going on, and she talked about crowd control, come in, go stand in a corner.
Yeah.
If you've never seen this, if you don't really know what to do, come
Stand
in,
at
go
the head
in
of
the
the bed
corner.
so you can see
true, yeah.
anesthesia, or right next to anesthesia.
Just be out of the way, but it is great to come in and just take it all in, watch what's going on.
But anyways, okay, Amanda, the pan.
Okay, so you've taken everything off of the top of here. The patient is prepped, the patient is draped, the patient has suction open. This is going to be your primary working surface. Like I said, this is going to change in 6-ish months. We will go over new things then. But for now, this is what you're going to see. It will be taped. You should run your hands around, pop all the tape first. You're sterile when you're doing this. Unwrap it unsterilely. Now that you're sterile.
We need like the S and then.
I know, I'm like, switch,
Yeah.
switch, switch.
So yeah, once you get that off, you're sterile.
This is about what you're going to see inside. Stringer of instruments, forceps, retractors, chest retractors that may or may not be there depending on how SPD is feeling. A big pair of scissors and wire drivers.
Talk to them about the stringer too.
Oh,
What
this
comes
is
in
where
there?
things are usually tucked, so know where to look for things. You don't have to move anything around. You'll see us, if we come in, we'll start moving, organizing, toweling things, being a little bit crazy, but this should be pretty much ready to go. So your wire cutters are going to be slipped in here. They can cut anything with these. If they have decided that they cannot use these and they need the double action wire cutter or the cable cutters, those are in the cart.
And to be honest,
But that'll get through a cable in a pinch.
This can, Liza may not.
not easily.
Yeah.
So I would be prepared
A man's hand
to,
is helpful.
and honestly, and Amanda and I were talking about this because so there's 3 different things. There's that, which like that cuts like the basic Dr. Spear single, those regular wires,
Yeah.
okay. The double act, do you have a double action?
I have a double action.
So this is a double action, meaning if you know tools, it ins and outs, it opens and closes by itself, that's what double action means,
It's much
okay?
easier.
And it's a lot stronger. Now the cable cutter is about in between the size of those two, and it is the thing that actually comes to cut those cables. The double action wire cutter will cut the cable cutter.
Is that
And-
Tony's cutters?
the old, that's not, he used the
The
actual
cable
cable
cutters.
cutters.
Oh.
But the other thing is you have the double wires now, which are very thick, and I think you would be that little one, I don't even,
So-
you'd kill yourself trying to get
So yeah, it depends what surgeon you ask. There's a lot of variability in this. They, according to Ryan, a double wire is just 2 wires right next to each other. If you untwist them, it becomes 2 single wires that you can cut with this. Some of them really like this because you can get in closer and cut closer. The angle on this is really, really
And that's
awkward.
bulky, but it cuts like
Yes,
butter.
but it's really, really
It's like a
fast.
hedge cutter. It's like-
At the moment, this is separate. This and the cable cutter are separate.
But they're
Eventually,
both on our card.
they're both on the cart. They're both available to you. Eventually, all 3 of them are likely going to be in
What's
here
that
and
one
available.
called? Double what?
Double action.
Double action.
Yeah.
Just let it
And
look.
those are the things
What you
that we'll have her
have,
put,
double action cable
and
cutter.
then cable cutter, yeah, is kind of in between the size of those.
Liza, how do you know what you got on the chest?
You should be able to see. on
X-ray or
X-ray.
op note, right?
You should be able to see on
Can you
X-ray.
see the double?
Yes, definitely. They're way thicker. Look at one of Dr. Ryan's patients if you think about it.
Does he
like-
use a
He usually uses, doesn't he start with 3 singles?
Okay.
Or does he go with all
He's-
double? It depends.
He's been changing.
You might see some singles and then doubles in the middle, but you can tell they're way thicker. They're like, you can see like the braid on there. So
He usually doesn't figure of 8 the doubles either.
Does not.
Does not figure of 8. So if you see a thin figure of 8, it's going to be a single or a cable. If they're only 4, it's for sure a cable. No one is going to single wire and only use 4.
Yeah, you already.
So, but again,
So you can figure 8 cables.
yeah, you can, yeah, and they usually do. But again, if you hand them this, some people for something else, but almost all of the guys will be able to figure it out through with this.
Good thing about the plates, there, didn't they say that there's the one, you can just cut, can't you cut them with the saw?
There's a pin.
Because
pin in the
I know
middle
there's a
is
pin,
ball.
but I thought that there was something else that you could get, but where do we have the pin?
Uh,
That's the next question.
So they are actually just kept together. All of the plates are kept together. So
You
it
just
looks,
pull it out, right?
yeah,
Just stick a hemostat in there and
it
pull
looks like
Yeah.
one plate. It looks like one plate, but it's actually not. So when we put it in as one plate that's screwed into both sides of the sternum. But that plate actually is divided in the middle. It's actually 2. And all you have to do is pull that pin up and
You
it
just
will
grab
pop
it
and
and
it
It's a
will
lot harder
pop
than it
across.
sounds, but it can,
Yeah, you do have to grab it with the hemostat. The directionality
Yeah.
is sometimes difficult, but it's,
Yeah, let's
But
go.
it's-
We're not
yeah,
doing that.
yeah. But also don't start looking for
The
screwdrivers.
other thing for that is
Because-
too, is if you have plates, you
Unscrew
probably
it.
have flaps, and that's a whole different nightmare, and we're not getting in easy on that.
So, a current problem, again, tucked in here, you are going to find this knife handle. Leave it there. Don't bother with it. It is
Yeah.
useless. You do not have a knife blade that fits on that knife handle. But in the meantime, use this that is taped to the top.
Thank God for
Use
that.
the extra one of these that is in there, or use the metal one that is in there. The metal one that is in there looks exactly like this. It is not. Do you want me to show them how to load
Yeah.
the knife?
Yeah.
Anyway, okay.
You can, but it's hard.
It's not that hard.
Worst case, like I said, I've had to just give up, get a blade, and snap it with a hemostat and cut it up. Because after like trying 10 different combinations of blade,
Yes, this will be 100% easier
Yeah.
always. If for some reason you already get into the chest, and they're never going to use a 10 blade in the chest. So if you get further in and they need another knife blade, that is when you'll need to use this. So this, these when you're opening the sterile instruments, and I have some more back there that are bad that need to be used if you want to try. You have to pop those corners first, and then it's exactly like opening gloves. Open it onto the sterile field. Like I said, they look exactly the same. Well, one is a little bit bigger, but they look for the most part the same. This side, you'll notice, is different than this side. This has a diagonal, and this is the side you're loading onto. You want it up. Knife blades, we're telling somebody where we've thrown it so they don't slice their finger off. And then for me, the easiest way to load a knife blade is with my hands. It's clean. And the easiest way to take a knife blade off is with a needle driver when it's dirty. So you're gonna hold it at this solid area up at the top. This is an 11 blade. I meant to grab a 15 blade so it wasn't quite so dangerous. And you're gonna slide it on, and you're gonna pull it down and it's gonna click.
I mean, once you really open the chest with this, you shouldn't have to do.
yeah.
We should be here by the time you need
If
this.
they need, if they're doing.
Actually, my end goal is to have a 10 blade in the pack, but also to have a 15. Actually, it'll be an 11 blade, to have an 11 blade of one of these, so no one ever has to load anything. They can cannulate with an 11 or a 15, so that will be there for you. But again, this one that is in the pack, I would quite honestly leave it tucked in there because all it's gonna do is cause, confusion and anger. Oh, stringer. These,
Teach them how to open, actually,
these,
that's important.
yes, so, knife blade. These are not supposed to be on the stringer. These are wire twisters. They look like needle holders, but they are more blunt. If you are panicking and you cannot find them, a needle holder will also work. What they need is something that is grippy and not serrated. So a lot of the clamps here are serrated, and these are more like sandpapery, for lack of a better technical term. They are more blunt than a needle holder, and they will grab, and they'll want to untwist once or twice before they cut.
And just, that might be something to go over too, if you are helping the surgeon, so they've made their incision, okay, and they've either used scissors to get down, you're down to the bone, you can see the wires, okay, you have to kind of make sure each set of wire is exposed. Now you'll either see the cable crimper for each one, or you'll see a twist, you know, where the wires come together. What they're gonna do, if you're helping them, either you or them, a lot of times it's me, I feel like, because I feel like they've got the cutter in their hand. You would take that wire driver, try to pull up on the little twist if there's a twist, untwist it to give it a little bit of room so they can get the cutter in there. They'll cut, and then you pull. So if they're untwisting it, there'll be a wire there exposed, and then you would cut that, and then you guys can pull it out. Same thing, you know, with the cable, you have the crimper. You're just looking for that crimper and cutting right next to the crimper, and then you can pull out from there.
And again, these or the double action will also cut the cables. Give them something sharp to cut. Sing actually said that scissors will cut the cables too.
I think, yeah,
So,
the heavy scissors.
there are two ends. One is connected, you're not gonna open it from here. Hypothetically, the scissor end, there are a couple different kinds of stringers. Most of them you just like pull up a little bit, pull the pin out, and then pull from the other end. It is super helpful to us when we come if this still looks like this. You should, in this area.
After I get it then.
In this area. See how it sits so nicely on this roll that they have already made. My point is, don't do this motion on top of the patient's legs, or don't dump it this way. The surgeons can sometimes find things when they're laid out like this. And if it's relatively in this area, it will help us a lot. We know that you guys are absolutely doing your best, but to manage their expectations and try to like recover things at the same time is really, really hard.
Can you pass that around just so we can see how
What, this? Oh,
yeah, just to see this mechanism. It is sometimes a little tricky to.
It's happened to me. I
Yeah,
couldn't
see
get
it
it
like
open.
that. So you get to play with it. You know.
So, and there's one, and chances are there's actually an older stringer on there that comes apart in the middle. Yeah, that has like a little pin in the middle as well. Just know that it's only gonna open on one side. And it's either gonna be, like in the middle or kind of at the top like that. Some of them, the older ones, are not as clear cut or open. Again, this is newer, and that's what you'll be seeing hopefully more frequently. Just a review of the instruments that are here. Start with scissors. There's also big black scissors. These do not go in the chest. These go in the chest. There's just general, they will call them clamps, hemostats, a variety of things.
Those are good for anchoring things too. Like when I was saying, this is kind of a bigger, but you know, a hemostat is a good thing to use to anchor your stuff that you're throwing off. And yeah, the same thing. They may call it a hemostat. They might call it a clamp. But if they say clamp, that's probably what they mean.
Smaller, straight hemostats. These are longer curved. There is an alley chest tube passer. This is not going to be an emergency tool. This is essentially just a long hemostat. It's called a Adson tonsil. Ryan calls it a snit. The most common thing you're going to use this for is they'll ask for it. They'll clamp like a pericardium or something, and then have you hold it up to retract with it. Probably the most important thing later are these tubing clamps. You are not going to use these emergently. You probably won't use them until we get there, but it's something to make sure that you leave here, because when they decide they're going to go in ECMO, we need these, and we can't really spend time looking for them. A right angle.
Should be in the ECMO cannulation kit. Like
There are a couple.
Yeah, there are a bunch in there. We'll probably bring our ECMO tray as well at that time, but for some reason there's always a shortage of clamps. These are Lega clip appliers. Maybe something that we will use.
Handle matches the color of the face. For example, is this something you want to?
Yeah, you can open
If
it.
you just put it right there, he will load it.
Yeah, they can load. This is something they actually could probably do themselves. But
easy.
as you can see, yellow goes with yellow. The blue clips will go with the blue. If you did have to load it, yeah, you just push and there you go. And sometimes they misfire or fall out, you know. But anyways, so that's it.
What was that right angle thing you had? This is just, these things are serrated on the inside. So like the hemostats, the Adson tonsils, all of those things. This is the same texture on the inside and essentially for grabbing things, or a lot of times they'll use it to get around when they're dissecting. In this situation, everything that they need to get around, they should have already gotten around. That should already be freed up. So I don't know what necessarily.
There's a hole in
Well, I
the
was gonna say
atrium.
I have used that to clamp a hole in an atrium before, to stand there and wait for somebody else to get there to
This
fix it.
this set has a globber in it, which is better.
Mm-hmm.
Better.
Yeah.
These two are the vascular clamps. I'm blanking. Crayford, thank you.
That they might use to clamp the aorta if they had to do something crazy, but we were thinking they probably wouldn't be 10 VA with it. If they on bypass,
Let's
Yeah.
not.
That would be ECMO at that point,
Yeah,
not really
yeah.
going on bypass.
Yeah.
So a Crayford and a Glover, they will probably just ask for a vascular clamp. These are the two that you have to choose from. The inside is different. It is more delicate, more gentle. It's not going to cause a lot of trauma to the tissue. If they ask for a padded clamp, that is a whole nother set, a whole nother adventure, and probably a bigger recovery. But in the case of an emergency, these will clamp almost everything that you need to clamp. And then the last thing are needle holders. There's some forceps.
Those go to gold handle,
Forceps?
the needle holder.
Oh, the
Yes.
needle holders, they're called
Just in case.
Mayo Hagars and Syrahs.
So are they always gold? handle?
Usually, yes. Usually,
The
yes.
tip you can see. when it's-
So the Mayo
Yes.
Hagars, yeah, are a little bit heavier. This is not something, even if they're feeling super particular, they are not
If you,
going,
if you gave them whatever.
yeah, they're not gonna care. You'll be able to tell though, a smaller needle should go on a smaller needle driver.
And another trick until the OR people come, get your tray closer so you can
Right.
reach
I usually
and
put it
grab
over
it.
the,
Yep.
Yeah, because you might be
Because
passing
they can just grab
instruments, so.
Or they can grab it themselves.
Or, or put it closer enough for them to grab it.
Yeah.
Well, they expect you to be certain.
This real quick, positioning, this is the surgeon's side, okay? So if you're helping, you're gonna wanna be on this side of the patient. I will tell you though, that if you're doing cardiac massage for some reason, do it from this side, because you can't get your hand around the left ventricle very easily from that side. You have to do a weird two-handed thing, it's not good. I have small hands, so I have an easy time getting my hands in the chest, but, and we will talk a little bit more about cardiac massage. But, yeah, just so if you wanna know where to stand and be ready, stand over there, because they're gonna be on the patient's right-hand side. So if you want this tray near them, put it right next to them there. And ideally, if you have enough people, you would have someone scrubbed here to stand to help, and you might have someone scrubbed there to maybe help pass the instruments to the surgeon, so that they don't have to, because think about it, every time they have to look at the tray, they have to look away from what they're doing, and sometimes that just really takes a lot more time to kind of go back and forth, just visually from that. So, tray, I know it's a lot, we will get kind of picture cards with some of the names that you, in like just a little, flip thing that you guys can kind of keep in the office and eyeball, just so you're familiar with some of the names.
The more you get
how about
involved
the
in it,
retractor, how do you use it?
Oh, yeah, that's a good question.
So this is similar to the retractor that's supposed to be on the tray. It actually only has one bar here instead of two. If you want to be helpful, put it together this way. It twists open and it twists closed. Put it together so they can actually put it in the chest. And
Keep
then,
it closed.
Mhm.
Keep it closed.
yes, you want it together and closed so that it goes in the chest. These are just made to hook on either side of the sternum, and then they'll twist it open, or you can twist it open. They'll
and
twist
make
it
sure
open.
nothing is caught
That's
on
the other thing to think
leg.
about, yeah, and I would, unless they're not there, I would sort of let them put it there, because, first of all, the pacing wires sometimes stick up, and when you crank the chest open, you pull the wires off, which may or may not be a problem, depending on if you're
or
using them or
graft.
not. A graft can be up there, you can get a graft, stuck in there, so.
I honestly don't think you'll ever say if you're non-surgical to open without them.
Yeah, I don't think so.
But I think if you do this much and they come, just put their gown on and get going, you just save 20 minutes.
Once you open, you lose your CPR.
Unless you're doing cardiac
Unless
massage,
you're doing
that's the
cardiac
thing.
massage,
That's the
then
thing.
you're-
And you gotta have the retractor.
Gotta have the
Yeah.
Yeah. Very quickly, how we're gonna kind of put all these things together, and I think Sadie wanted to sort of go through maybe a quick, like, scenario of, what we might do. Obviously CPR first and foremost, and I think everyone's pretty good about that. But Courtney did have the good point about having sterile people armed and ready to go for, doing CPR when we have to change out. Because you get tired fast. I don't know when the last time you did CPR was, but I actually ended up doing CPR like a month ago. Or that same, the
Use
same
your
patient.
most muscular.
Oh my God, delegate jobs, okay? If you're the ICU person, take charge of the medical situation. I guess we have, 3 people at night now? So, that person's doing the medicine. Probably what I would do if I was delegating is I would have one person assigned to, get the stuff off there, start opening things, and get prepping. And then I would have someone else getting sterile already and ready to go and to start draping once everything was opened and prepped. So that might be a good place to start. Go ahead.
Move the bed.
bed down, because
Yes.
you're gonna have a ventilator, you're gonna have all these
And if the
IV
patient
poles
is
and
intubated,
everything.
yeah, think about that, because they'll have to be up the side of the bed, to re-intubate the patient. And they, they take the patient off, they usually bag this whole time, so you're gonna have a respiratory therapist up there bagging, the entire time usually, while this is happening, so that's something to think about. So start your CPR, call the surgeon, there's someone else, hopefully, obviously that should be an APP that's calling the surgeon, so, you might have to multitask, but get them on the phone, let them know, try to communicate what's going on, and so that they know, what the situation is. Ask them, if this is a situation, you could usually tell, but ask them if they want, they want you to prepare to get the chest open again. And that's gonna mean pulling your chest cart. You guys know where those all live, back there and up in front here, by, across from room 23. That one's back by 12. There's a Mayo in each position too, so if you start with your cart, your Mayo, that's gonna start to give you kind of everything you need. I would pull the line cart, someone get the line cart too, or have one of the nurses bring the line cart over. That's gonna have some extra gowns, gloves, things like that. And obviously, someone at some point is gonna need to try getting lines in the patient if we don't have, that good access. Crowd control we talked about. Sternal saw, like I said, you're gonna know if you need it. If it's a mini thoracotomy patient, have somebody run and get that also. And I'm sure Lisa, the nurses are they all know where that is now too, right? In the OR, where the.
They were gonna put it up on top of the open chest cart.
Yeah, okay, good.
We went over it on Monday's class. We're gonna
Perfect,
try to
yeah.
go over it.
Just because it probably will be a nurse, everyone's gonna be doing, probably will be a nurse that has to go grab that if it's something that we do need, so just think ahead. And like I said, the bovie and the paddles can wait unless, paddles out, get them out if you think it's something that you're gonna have to shock once you get in there. The bovie is a kind of a secondary thing, like Amanda said, if you think of it, slap the bovie pad on. Get your Mayo, get your, your drape, and like I said, and you probably, the towels make it a little cleaner just because this never sticks and this shifts, you know what I mean? So if you can throw towels on there, I think that's great. You can probably ditch the 1/2 and 3/4 drapes because this drape is a lot better than the ones that I was used to seeing. And then like we said, think about your transitioning to your sterile CPR. Someone's doing CPR, as soon as you get that betadine prepped on the chest, you've moved everything away, the sterile person jumps in, and then, somebody think ahead to try to, get other people ready so that they can kind of trade back and forth. If you have time, get your drapes, everything on, and like I said, it will depend on how fast the surgeon gets here. You just keep going.
Sometimes they get stuck in traffic.
Sometimes they get stuck in traffic. So, they may be here before you're even, to this point, but ideally you're so fast that you've got this all done. Once you have yourself draped, pass your suctions off. That's your most important thing. Like we said, get the suction tree in here. Lisa had the good point that it can live outside if there's not enough room. Pass your tips off. Try to remember not to throw those plastic things away. I've done it myself 1,000 times. Anchor everything to the drape with a hemostat. You're probably not going to be using hemostats for a ton of other things. I was
Those
going to say, and these are
Velcros,
nice. These
yeah.
do work. They're not perfect because things will slide down, but especially if you're in a pinch, you can use those to anchor things and throw them off.
Just remember also the nurse needs access to their IV so that they can push your meds for you while you're coding the patient.
That's a good point. And yeah, that's why I said pulling the bed down also does help with that because you have a lot of people that are kind of crowded around the head. We talked about having gown and gloves ready for the surgeon, and even if you don't feel like you're going to glove them, that's fine. Find a surface, open up a gown for them, and pop gloves on there. Put a 7, 7.5, whatever, and they'll be able to get their hands into that. Make sure everyone has there's hats and masks that are available for people. It's not the end of the world if they come charging in and don't have any hat and mask on, but ideally having that on. And then, like Amanda said, once we get everything ready, the first things you're gonna need your knife. You might need a set of scissors to kind of cut through things. Usually, they're just gonna cut right down to the bone. You're gonna need your cutter, whichever one, and familiarize yourself right now where those other two are in case they ask for those. If it were me, I have a hard time using that one to cut wires. I really do, unless it's just the single wires, and you hardly ever see those, anymore. So I have a really hard time using that myself. So those are on the top shelf, I think, over there. They're on the left side. So know where those are in case somebody asks for those. I would pull them out, get them in the room, get them where somebody knows where they are. And then if there's time, there are lap sponges and Raytex. I think those are over on the
Far right.
far right, right?
Mhm, yep.
If you have time, I always like to have at least lap sponges, which are the big lap sponges are the big ones that are like about this big. Raytech, or 4x4s, they might say, are the small ones. They're gonna be wrapped up, but they'll come like this. These always come in a set of 5. These come in a set of 10. Ideally, try not to throw these away because technically, like you're supposed to count, but I don't know. You
For sure, 1 or 2 nurses that are gonna come here and be like, and how many needles do you have open?
and you're like, I have absolutely no idea.
I don't know, there are some and they are there.
Needle mat is where on there. That's the other thing. right?
Needle mat is in the middle, 3rd row.
In the middle. Okay, so that's
And-
something else that you might need if you start getting into needles and stuff. But
And
anyway,
again, all of that stuff will hopefully be in that pack, so you're not.
but these are good because you can pack
And,
these.
and
you
maybe
can-
open the card and start memorizing where things are.
Yeah, definitely.
Each one of them.
I would open laps first. This is gonna soak up blood,
Mhm.
pack things, other things like that. The Raytech are gonna be
Your finer stuff.
Yeah.
kind of, or-
after a big hole in the heart has been fixed, something smaller like that to stop bleeding.
Yeah.
I don't know,
Or
but this.
retract, or somebody use them to retract with. The other thing put on here that I've found useful is a basin. Like there's, a lot of times there's tons of clot in the heart and they're shoveling it out onto, you
And
know,
they'll
all over.
just put it
They'll
on
just
the
put it all
field
over the
or-
place, which is not the end of the world, they can just throw it down there, but having a basin, cause then a lot of times they might wanna irrigate, if it's something that does get controlled in here, you can dump that out, you can get some sterile, saline in there, they may wanna irrigate, or sometimes to find out where the bleeding is, you need to irrigate, so the basin is nice to have for that, but that, like I said, that's kind of a,
There are 2 metal basins in that cart at the moment. Basins will be something that will be in that pack as well, but for the time being,
And we have
They
warm
are
saline.
Warm saline.
Warm saline in the warmers.
Bucket, a warm saline.
when the surgeon arrives, obviously, they're gonna need to know about the patient if it's not their patient. And this is a good, something to delegate to somebody to pull the operative report up, either outside or, you know, we're kind of way inside here, so maybe at this computer. Get the op report. That's gonna be really important to know, especially in a bypass patient, because having grafts on the heart and doing cardiac massage are dangerous things. So if you had to stick your hand inside, like I said, the easiest way is to do it from the surgeon's side, because the left ventricle points down this way, and that's what you really want to try to get your hands around. My hands are small enough that I have a hard time doing it with one hand, and also what you have to think about, it's really easy to put your fingertips through the heart. So what they will do, you just slip your hand over and kind of get your fingers underneath, and ideally the ventricle is sitting here in your hand, and you're kind of squeezing like this. For me, I can't do that very long. I have to kind of get this hand in here flat, and I take this hand flat on top, and I kind of do it two-handed that way. Something to think about why you don't just go charging in there. If it is something that's just like an AVR, which we hardly ever do anymore, you're a little more safe. If it's just a valve or an ascending, you're a little bit more safe. Just know that the wires are there. The ventricular wires are going to be down on the ventricle there. They're going to be kind of in your way. If you pull atrial wires off, it's probably not the end of the world. It's the ventricular wires that are going to keep the patient alive at the end of the day, and it's easy to put atrial wires back on. But those are just things to think about if you're somehow do end up sticking your hand inside there. Your most dangerous situation is if you have a patient with bypass grafts, because also what you can't see kind of right over here is that's where the your Lima LAD graft will be, and of course that's attached right to the chest too. So if you stick your hand in too high, you'll tear that right off as you're going through, and then that's a really big
well,
problem.
and we're doing an ever increasing number of remas.
Remas
too,
too, so you may
you're
have
not
two things
safe.
attached, so I would very much caution you, unless the surgeon specifically tells you to ever stick your hands in the chest of someone who's had bypass surgery. It's you just really have to know, and even for myself, for everybody, it's dangerous. And the surgeons, that's why they really would want to know where the grafts go. So that's a big deal. And be prepared with gown and gloves, everything that the surgeon needs. Suction, make sure the suction's working, ideally. I told you what they're gonna need first, your knife, maybe your scissors, your wire cutter, and then your wire twister. And then you may have to pass instruments. So I guess the final things, stay calm. They know this isn't your thing, but they can be pretty intense, and sometimes it's hard not to take that personally. But their only thought is to keep the patient alive. they don't really care what's going on, and it's not about you. You know, you just have to remember that they're not thinking about you at all. They're just trying to think of what do I need to do to get this situation back under control, you know.
Two things to remember: if they're bleeding, you might want the meth transfusion protocol to be started, and then also let the ECMO specialist know that you have a patient that might be going on ECMO, so that they can get their stuff ready.
Is that part of the ECMO specialist part of the call for the?
Well, they're here.
They're in-house.
Specialists are in-house. Perfusion is part of the
Yeah.
call, but
Well, just not the one that's in the unit now.
Yeah.
And the surgeon calls
Perfusion will
the
come
team.
with the
Yeah.
team.
Are they the one who's responsible to activate the team?
The surgeon is responsible to call access and activate the team.
Okay.
yes, they're supposed to do that. Listen to what they say, but try to think ahead. You know, try to anticipate. That's basically what the first assistant's job is, to try to help them when they need it and to anticipate what they're going to need next. So it is logical stuff. I mean, obviously you open the chest, there's a bunch of blood there, you're going to need a suction. I do caution, like I wrote here, unless they tell you, don't be jamming that sucker in there, you can cause problems. But if obviously if it's overflowing, stick it into the pool and, you know, get it under control before it's all over everyone's feet. And if basically if you find yourself that they're sewing something or cannulating, something where there's suture involved, basically try to provide exposure, meaning try to, wherever they're sewing, try to make it so that they can see where they're sewing, and usually that's using a sucker carefully. They probably will position it for you and just say, hold this here, to kind of keep that area exposed, and try to keep the suture from, you know, being in a knot. I mean, following a stitch is basically, that's the point of that. And if you don't necessarily have to follow, but just try to keep the suture from turning into a big wad, and there's nothing more frustrating than you finally get to where you're trying to do something. The stitch is all knotted, you have to cut it out and start again. So that's, you know, a frustrating thing. So if you just try to do a little bit of stitch management, those are probably the two most important things. And like I said, don't stick your hands in the chest unless they tell you to, just to save yourself from.
The mental note, almost all of the suture that's on the cart is double-ended. Just pick, if you have to load suture for them, pick what you're going to do with that second needle and keep track of it, because that's what's gonna get in a knot. You can either load it or you can hang on to it. I wouldn't suggest holding onto the actual needle, but the stitch a little bit far away from it. And basically what she was saying is just don't let, that's the part that's gonna get
Tangled. It has memory,
tangled.
so it's all the, you know, the prolines, they're gonna wanna just wad back up on a ball, keeping that other end from, you know, kind of all wadding up and falling in there,
Just,
so.
just for yourself, remember that there's another needle on the end of that.
Okay, that's what you mean by double loading.
Oh, yes, I'm sorry, it's double-ended, there's a
That's okay.
suture, when you pull.
There's a needle on both
There's a
sides.
noodle,
Yeah.
a needle on both
Yeah,
ends, so
okay.
if you load one and give them one, just know that there's another needle somewhere in your vicinity to keep.
Or if they're
keep
done
track
looking,
of.
I guess
or if
it's
they're
just
done
to make
looking
it
at you,
easier.
they're probably looking for the other side of it, you know what I mean? Or we'll take over when they arrive, like Amanda said, make room for them, just make sure somebody lets the family know, because a lot of times all this drama is going on and we forget, like, oh, did somebody actually let the patient's family know? Most importantly, Amanda's gonna show us real quick
I'll
about
just say
the
that
saw.
also, like,
Yeah.
if you see somebody doing something wrong or ordering some medication wrong or whatever, or defibrillating potentially, you should say, you should
Say
use those
something.
cuss words. I don't know if you guys learned about
Yeah.
the cuss words. I'm concerned,
Yes.
I'm uncomfortable, stop. And
Real quick, guys, Amanda's gonna kind of just show everyone, and I asked her to maybe put together a little visual card to take to where we make this saw live, in case, God forbid, anyone else has to do this by themselves.
This is what you're gonna get. Remember that internal defibrillation pedals are going to be coiled on top of them. If you don't need them at the moment, I would suggest grabbing them and just sticking them at the bottom. This is a different opening system than maybe some of you guys had used. It's gonna look like this when you get it. This is gonna be closed, and there's gonna be tabs through here. These tabs just pop off. They break really easily.
When you flip those up, it'll break that.
Yeah, you can also just flip them up and they'll break. So I'm gonna have everybody afterwards come just like see what this feels like. This saw is on that cart in the CBOR.
We're gonna do our
Okay.
little walk real quick if we
Yeah.
have time.
So on that cart, you're gonna open it and you're gonna see a saw blade, and a battery that is wrapped in one of these two ways. They are exactly the same. It's just an SPD, which is who does all of our sterile instruments situation. This one is wrapped a lot like that Mayo is. You have to pop the tape and basically hold it here and then unwrap around. Or this one opens like everything else, and I'll open this one because it's easier. So you're gonna wanna open this onto a sterile surface, not onto the patient's face like I am. preferably. Open your saw blade onto a sterile surface. Pop this open. This should come up and straight off over the top. And then if you're scrubbed, you can grab these inner handles and pull this out and take this to another surface that feels safer, closer, better to you. A lot of times stuff ends up getting, at least by the time I get there, stuff is like being opened on a surface out there and it has to be transported in. So that's what this comes out. Those paddles can come off, and I would suggest making sure you grab those two black parts that get inserted as well, even if you don't put it together then, just keeping it together.
Yeah.
Keeping it together and keeping it sterile. Foot of the bed, another surface, whatever you can. And then you will find this and this. This is important. It is silver. It looks like everything else in here.
It's impossible to find. Yeah.
Yeah. Okay. I know. That's one of the reasons why I would suggest just picking this whole thing up and taking it somewhere with you, because then you'll, one, be able to see it better, two, have everything there, and then once you have the saw together, if you want to give this to somebody, you can, but you'll know that you have it fully assembled and you're not missing any pieces before you hand this off. Okay. So this is really something that is easy to do after you've touched it.
Easy if you know how to work a real drill. I feel like it's
Yeah,
similar.
it really is. It really is. Almost this. So saw blade, you can see serrations on one side, not on the other. Almost all of them saw up. Any of them can saw in any direction if they have
so
to.
if it's the wrong way, just say use it.
Yeah, we're gonna learn how to do it up because that's what most of them do. So serrations up. This rotates. There's two rotating pieces. This rotates and this rotates. We're gonna start at the tip, do this first. This rotates and inserts. Maybe, if I can see. Sorry, I'm trying to do it so I can show you not the way that I do it. And you'll see there's little flanges on the side, on the top and the bottom. Those will fit all the way in, okay? And then that'll click back.
Okay.
This is this part. Okay, also up, right? If you do it this way, is that gonna work? No, because your serrations are here and your access is here. So this swings, this fits in, and it's kind of the same thing. It'll click and pop back, okay? Again, once you feel this and feel what it's like, it sticks with you. It's like that muscle memory thing, so if everybody gets an opportunity to do it once, it's really helpful. Saw battery slides in, and you have to like really beat it a little bit. It clicks in. This is your safety. In the middle, it is often safe, okay, in the very middle. One is faster than the other, but so pushed other ways. I, especially in this situation, would always hand it up safe. I do not load the battery until the very last step. Please do not put the battery on and then be messing with the blade for everyone's sake. You getting your finger cut off is not going to help anyone in any situation, right? Get all of this fixed, get all of this set up. Same goes for at the end. You're gonna take the battery off before you unload it. You're gonna take there. Okay, so this has to be on all the way. It has to click. If you feel comfortable testing it before you give it to them, test pointing towards something. What will happen is this will sometimes not seat all the way, and then when you test, it, it shoots and actually gets a little bit dangerous. So, if you're comfortable, you can test it. Otherwise, I would just let them know this hasn't been tested yet, so they have a second to do that. I will pass it around.
This is the kind that you're gonna need if you need to do a sternotomy.
Yeah.
Here.
The only other hypothetical, we use a redo saw when we're back there. So if you have a redo patient that codes pre-op, that's not good.
Does anyone want to play with this mechanism?
Yes.
Okay.
Yeah, go ahead.
So how do you get it off?
So it's gonna be, did you already take, yeah, so do this one first.
Push it in?
No, but it rotates, so push it around towards the
I'll wait
middle.
in line.
No, push the button and then turn the thing.
Yep, it's like a collar that rotates. So yep, rotate the collar and then pull that off. And then you're gonna rotate this collar and pull the knife blade out. Saw blade, sorry. There you go. Yep, and then same way to put it back together.